Welcome to Green Time. I'm host Don Fitz. This episode we're going to be talking about socialized medicine in Denmark and compare it to what happens in the United States. And I have two people who are very familiar with two different medical systems. I have Mimi Signor, who has been on Green Time many times before talking about the American healthcare system. And Mimi is a president of Missourians for Single Payer. I have Johan Andersen, who is with the Department of Occupational Medicine in Aarhus. Is that pronouncing that right?
Aarhus, yes.
Aarhus University in Herning, Denmark, and is currently a visiting professor at Washington University in St. Louis. Now, Mimi, tell me, what's your connection to the medical field?
I'm a registered nurse, and I've been working as a nurse in a hospital setting for more than 35 years.
Okay, so you have a little bit of experience. You've seen a few accidents in your day.
Yeah.
Okay. And Dr. Andersen, tell us, why are you in St. Louis now? What are you doing?
I'm in St. Louis for 3 months doing research together with colleagues on the Washington University, St. Louis School of Medicine.
Okay, and you do research in Denmark?
Yeah, I do research and also patient-related work.
Oh, so you both are research and a practicing physician. Okay. Mimi, tell me, do you see any problems with the U.S. medical system? And you only have a couple of minutes, you don't have 3 hours.
I get it. Well, first of all, we don't have a system, but the problems in our non-system, I think the one major problem is the inequality in health care. We have different levels of quality of care for different socioeconomic groups, and health care is allocated according to ability to pay instead of health care need. So I think inequality is number one. But number two is the huge expense. The dollars that are intended for health care don't go directly to health care. They're filtered through these blood-sucking middlemen called insurance companies, and so very little of the healthcare dollars in the U.S. actually go to health care. So I think those two are the big problems.
Okay. Dr. Andersen, you've practiced medicine, or you've been familiar with the medicine in both Denmark and the United States. What do you see about what do you see as differences between the two systems?
There are huge differences. And I'd like to paraphrase a recent book that came out at Chapel Hill in North Carolina by the author Norton Hadler. The book's title is By the Bedside of My Patient. And I'll quote him from that book in saying that today health is a commodity, disease is a product line, and physicians are a sales force in the employ of a predatory enterprise. And I think that covers it real well.
The U.S. system.
Yeah, in Denmark, all healthcare is publicly funded without no money between patient and doctors. No bill to make your daily life broken. No out-of-the-pocket expenses that could bother you or your family. Hospitals are owned by the state, and there are no private universities. Doctors and nurses and all other staff are on paid salary, negotiated by their unions. And doctors do not own facilities to make scans, blood tests, or whatever you like. And we use half of the money per capita than in the U.S. for this healthcare system.
You use less than half as much money.
And we have better outcomes concerning...
In the United States, I think the cost per person per year is between $8,000 and $9,000. Yes. So can Denmark provide care for half of that, between $4,000 and $5,000 per person?
And with better outcomes on life expectancy, infant mortality rate, and in international comparisons of the quality of healthcare. The US spend around, I think it's 17% of GNP on health. It is more than all other countries in the world. And the money does not create better outcomes for health. A lot of the money is wasted on unnecessary tests, over-treatment, as I see it, for the sake of profit, not health.
Well, let me ask you this. In Denmark, do doctors and nurses resent working for the state and being told what to do by the state?
They're not being told by the state. They practice medicine at the level of the evidence that is created in the medical and nursing communities.
Okay, well, let me ask you this. What's the connection between healthcare and social welfare?
I would say that social welfare is a prerequisite for health. Unemployment benefits, maternity-related entitlements, paternity and related entitlements, and sick pay are all important for keeping your health and your family in a good condition. And a recent comparison between US and Western European countries showed the US to be least generous on all these entitlements, and Denmark the most generous. Also, education is free from school to college to universities, which makes the possibilities to move across social boundaries much better in Denmark than in the US. And I have to say also, childcare is cheap, safe, and performed by well-educated staff. And if you're too ill to have a job, the state covers you with an amount of money that ensures you can still have a home, something to eat and live a life, and do not get evicted from your home.
Well, let me ask you, you told me that there's a difference between democratic socialism and social democracy. And most Americans would not understand that at all.
Well, I'll say that it's my opinion that there has never been a real socialist country in our world, not yet. Most so-called has been dictatorships or state capitalism, in my opinion. And the way our country is run has nothing to do with capitalism, socialism. We have a liberal market economy, free trade, free speech. We are a member of the EU, private companies dominate, and we have free democratic elections with around 80% participation. I think the big difference is that working people are in unions. 75% are unionized in Denmark, and in the US I think it's around 13%.
Well, I think it's down to about 6 or 7% now.
Okay.
It's been plummeted.
So I think the social democracy mainly comes from redistribution of wealth in our society by taxes, the free education and free healthcare.
Okay, we're going to take a break and we're going to see a few shots from the movie Fix It, where they talk about problems even with people who have health insurance not being covered fully. And we will be back in just a minute.
For an average family of 4, this year's number is $23,000. That's what a typical American family insured that way costs.
And they have this false sense of security that they're in a plan that provides them protection. But regrettably, all too often, people find out when it's too late, after they've been sick, after they've been hospitalized or injured and requiring expensive treatment, that their coverage was not nearly what they thought it was. And insurance companies are able to charge older people 3 times as much as younger people for the exact same policy.
Their potential employer sees them as a risk.
The age 50 to 64 age bracket includes very high rates of uninsurance within the U.S. market, and it's because these are very expensive employees.
It makes it less likely that employers will even consider hiring someone in their 50s, for example, or early 60s. I've talked to people who've told me they've not gotten a raise in 5 years because the money they would otherwise have gotten in raises has gone to insurance companies.
We've created a very fragmented system in which coverage is tied to employment in ways it isn't in most other countries in the world.
If you and your family lose their whole health insurance because of a change in your employment status, That's an incredible insecurity, an incredible burden for families to have to bear.
So the whole idea of having insurance that protects us from financial ruin, it just doesn't exist anymore for most people.
And this is why, of 1 million bankruptcies in the United States, over 60% are associated with medical conditions. And the great majority of those are people who have health insurance.
We went through years of working hard only to lose everything. Lose our home, go bankrupt. What a shameful thing to do to people.
You see these numbers of people who don't have insurance and families who are driven to bankruptcy.
If you talk to most families, they can identify at least one person in their family who's really struggled with healthcare issues and how to finance those issues.
40,000 unnecessary deaths every year because there's no health insurance. And these are real people who are suffering and who are dying.
Of course, I had health insurance, but I never actually thought a whole lot about it. I paid the premiums. I wasn't using anything that much. My out-of-pocket expenses were pretty much nil. But then Bill got sick, and he was hospitalized. So all of a sudden, these bills started rolling in, and my insurance wasn't covering everything.
In 2014, a family that was paying $4,000 to $5,000 as a premium share, and MCS was paying $13,000 to $14,000 as their share of the coverage, that family could pay another $6,000 or $12,000 if one or two people got sick.
We're up around $10,000 in expenses. What would happen if I would get sick? Our expenses would be probably up around $16,000 a year. That's unbelievable. If anything happens to me, we're done.
Welcome back to Green Time. I'm Don Fitz. This episode we're talking about socialized medicine in Denmark. And with me I have Dr. Johan Andersen, who is with Occupational Medicine at Aarhus University in Denmark. And I also have Mimi Signor, who is with Missourians for Single Payer. Dr. Andersen, you just, before the break, you described a very extensive social welfare system in Denmark, which provides complete free medical care to all the citizens. Is the government going broke is it running out of money by providing all of these social services?
Not yet. Denmark has one of the most sound economies in the OECD world. So they're not going bankrupt.
It's not going bankrupt.
No.
Okay. Mimi, tell me, why do you think that's different in the U.S.? I mean, why are Americans not demanding a system like Denmark, or at least a system like Canada, where there's some version of single payer or socialized medicine in virtually every other advanced industrial country?
Our democracy is based on representation. We elect people who are supposed to represent what is best for a society and the people who live here. But unlike Denmark, people aren't voting.
Not 80% turnout like in Denmark.
No, if it's 25% turnout, it's considered really good. Part of the problem is that the people who don't vote are people who are in the lower socioeconomic levels, and
people who would benefit most from socialized medicine.
The people who would benefit most don't see their power. Mm-hmm. They don't see their social power as individuals or as a voting group, as a voting bloc. And they're so disenfranchised because of their oppression, socioeconomic oppression, they're not voting, and they're not participating to make the democracy work. So
well, a lot of people just seem to accept a corporate system, an insurance-driven healthcare system, as okay. Why do you think that is?
They're accepting it because they don't understand that our government could do so much better. The corporations have thrown so much money into our government. The lobbies have really bought off our politicians. So really the laws that govern healthcare are written by corporate lobbyists. And so all the laws, all the rules, the ACA, all the laws are written by lobbyists rather than our representatives who are supposed to be representing us, but in fact they don't. Okay. And why do we put up with it? I don't think we're feeling our power.
Okay. Dr. Andersen, you've been in St. Louis for 3 months, and the city that you're from, Aarhus, has about 300,000 people. What sort of differences do you see in medical care in St. Louis and in Denmark?
There's actually some websites asking people living in St. Louis and in Aarhus and in all other cities that you could compare. And actually people are rather satisfied, both in our city and in St. Louis, at the general level with healthcare, but not for paying. There's 100% satisfaction in Denmark and in Aarhus, our city, but a much lower satisfaction with the expenses here in St. Louis. But in a general way, I also see visible inequality and inequity in the streets that I don't see at home. Just by riding a bus downtown gives you an impression of huge inequality that scares me in a way. And I have, from my car, seen some very strange neighborhoods in this city that we don't have alike in our country.
You mean very poor, impoverished neighborhoods?
And I have seen from statistics that there are household incomes in parts of this city that are around $5,000 a year. You can't do a living for that. There's no one less than at least $30,000 to $35,000 a year in my city. We're having the lowest income. So this huge inequality is, which Mimi also has mentioned, is a
Let me ask you something else. When you practice as a physician, do you very often see people with gunshot wounds?
Never.
Well,
in the city of mine, there was 1 to 2 gunshots last year, and the number here is several hundred.
Mimi, have you ever helped treat somebody with a gunshot wound?
Well, I've not been an emergency department nurse, so no.
Okay.
But I have been in the emergency department, and the security there is very great because of the shootings and the retaliation. People are terrified, so it's a very dangerous place to work, and to be sitting in the waiting room. There's metal detectors and policemen at the entrance. I'm sure you don't have something similar.
Okay. Well, let me ask this. Do you think that the safety net, the things that we have for people who fall through the cracks of the insurance system, do you think that they're working in the U.S. to make sure that even the poorest people get good medical care?
The poorest people can get Medicaid. The working poor, no. And we don't really have public safety nets anymore. We have closed our public hospitals. We had, city and City 1 and 2, I forget the name, and county hospital closed, regional closed. There's no public hospitals. And then the free clinics aren't free anymore. The ACA has determined that people have to pay something. So it's an insurance model for even the people who really don't have.
So virtually anyone who has medical care is going to have to pay something for it. And if you're poor,
Yes.
it's going to be very, very difficult.
Right. It's a different model than it used to be before the ACA.
Okay. We're going to take a break, and we will be back in just a minute. We're going to see another clip from Fix It about how Americans go into medical bankruptcies over not being able to pay medical bills.
Patient doesn't have to pay.
We are billing on behalf of University Health Network for 4 hospitals for diagnostic tests to the Ministry of Health. We don't see any situations where the ministry is second-guessing the doctor's clinical decision on the test. We bill weekly, electronically, and there are approximately 10,000 claims on those weekly billings. And those are handled by approximately 10 people within the department.
This myth about Canadians dying on waiting list is simply that. It's a myth. When people have something really urgent that needs to be dealt with in the Canadian healthcare system, it gets dealt with. The notion that having a single payer somehow causes wait times is not actually borne out by the international evidence on healthcare system design. We see healthcare systems internationally where it's a single payer system and there's virtually no wait time at all, Taiwan being a good example of that. We see systems that have multi-payers where wait times have been a big problem.
There's a lot of mythology out there that somehow there's a big tax burden or a big cost that comes along with the Canadian publicly funded model.
In my 25 years as a cross-border tax consultant, I'd say I've prepared at least 5,000 US returns and about the same amount, 5,000 Canadian returns. The surprising thing is that even though on an income of $50,000, the tax rates in Canada and the US are about the same, in Canada, that tax covers primary health care. In the US, there'd be additional cost to that person, either through their own insurance or employer insurance.
Canada now spends half as much per person as we do in the United States, yet their life expectancy has increased faster than ours.
Welcome back to Green Time. I'm host Don Fitz. With me, I have a couple of guests who know about socialized medicine or what it could be. I have Dr. Johan Andersen, who is visiting at Washington University School of Medicine from Denmark, and I have Mimi Signor with Missourians for Single Payer. Now, Dr. Andersen, what do you think could be a way for the U.S. to move forward, given the current situation?
Unfortunately, I have no quick fix-it, but I think that healthcare should be freed more from corporate business interest and insurance companies, which has no interest in the patients, only in profit making. And I think healthcare workers should be paid workers, as in other countries. I think the system is rigged, and only a large pressure from the bottom could change it. Not from the patients themselves, they are ill and vulnerable, but from those who still are well and must be doing the hard work.
Mimi, what could you add to what should be done in the U.S.?
Well, I have to agree, but we have to empower our people more. How to do that, that's up to us, isn't it? But at any rate, more people need to get involved in their government and make demands. We're not demanding health care, and we have to demand it, or we're not going to get it.
Right, and so if we're not out really publicly demanding, whether congressional hearings or demonstrations or wherever, resolutions, we really need to be active.
We need to feel our power as a group.
Okay. Mimi Signor, Dr. Johan Andersen, I want to thank you both for participating in the discussion.
Thank you.
I want to thank everybody for tuning in Green Time, and I hope you tune in same time next week.